Good afternoon, everybody, and thanks for joining this webinar, part of the Global Health webinar series. My name is Mark Tomlinson. I'm the co-director of the Institute for Life Course Health Research, which is part of the Department of Global Health. Before we start, and thanks for everyone joining. Just to say that as I'm sure all of you know, unless we have people joining from elsewhere in Africa or the world, we're in the middle of load shedding. I'm right in the middle, and I'm trusting my laptop battery and my UPS is going to last for the full 90 minutes. But if not, we'll just have to sort of make a plan. What we're going to be doing is I'm going to let each one of our panelists and speakers present, and we're going to hold questions for the end, except for one speaker. Dr. Naveed Noor has to leave early, so we'll have Professor Woodley's presentation. We'll then do Dr. Noor's presentation. Then we'll have 5 minutes of questions to Dr. Noor if there's any points or clarifications that people would like to make. And then we'll continue with the rest of the webinar, and hopefully we'll have a decent amount of time at the end to have questions and have a discussion. So I hope that's in order. So to start with, what I want to do is just briefly give a little bit of a background of where the idea came from around this particular webinar, and a discussion about how we do think that it would be good to continue this conversation. This is not a conversation that will end here. As every one of these panelists know, these are ongoing issues, and we will continue to discuss this. So let me just move through the slides. And so just part of this is about a discussion of what exactly conflict of interest is versus declaration of an interest, and Prof. Moodley will frame that for us in her presentation. But that's an important distinction, of course, is that declaring an interest is not the same as a conflict of interest. But something that I've noticed in the 25 years I've been involved in global health is there's been quite a shift in the way we think about things. So this is a slide that was put up a number of years where the two massive food conglomerates, Heinz and Kraft, merged. And these are largely American offshoots and sub companies of the two large ones. But the thing that many of us will know is that little one on the left there, which I think is very interesting, is that Weight Watchers at that time was owned by Heinz. That's not the case anymore, but a kind of a fascinating process where Heinz is one of the largest producers of junk food in the world, who then makes money at the other end of the spectrum around then getting people who want to lose weight onto Weight Watchers. Pretty much the evidence is that about 95% of people on a diet will fall off that diet, and then proceed to then go back and eat more bagel bites. And obviously I'm simplifying the process here, but this idea of making money on both ends is an interesting one. I became very interested in this area because I have a particular interest. Professor Sarah Skeen and I ran something called the Partnership for Alcohol and AIDS Research for a number of years, and very interested in alcohol issues. And this is when the new head of Global Fund took over. One of the first meetings was with Heineken around a partnership to fight infectious diseases in Africa. And again, one has to think about it. And I'm open to the debate. I'm open to issues around who the Global Fund, who a university, who a government accepts money from. But I would contend that at the moment we're not having much of that discussion. And then I started thinking about other areas where issues around conflict of interest play themselves out in quite profound ways. Many of you will know about this during the Bush, President Bush era, where the American Psychological Association and in particular two psychologists, I'm a clinical psychologist by training, we're part of a CIA torture program to try and get detainees to talk and to and the Psychological Association and these psychologists were embedded within the CIA. Again, I think these are issues we need to talk about. we've all seen what happened during the Trump era, where essentially the presidency became another one of his business investments. And closer to home, we in our department have had issues around funding that's been received from the Foundation for a Smoke-Free World, which essentially is at face value intended to stop smoking, but in fact is funded by and is a front in many ways for Philip Morris, one of the largest tobacco manufacturers in the world. This made me think many years ago, I don't know if this is true, but the Wellcome Trust in the UK had a policy that if any UK university had accepted money from a tobacco company, that the entire university would then be blacklisted for a period of time from receiving any Wellcome Trust money. I don't know if that's still the case, but these are issues that I think have fallen off a lot of our radars, and I think part of our aim with this webinar, and hopefully others to follow, is that we start a debate around that. And closer to home again, we all saw what happened during COVID, during the lockdown ban on alcohol, and I wrote this piece for the Daily Maverick around how the alcohol industry very cleverly used the very same playbook that the tobacco industry had used to counter lockdown bans, hiring scientists to query the science and a number of other things. I can send that if anybody's interested. And then I want to end with this particular slide as a way of framing our webinar. Is right now, as we know, Putin has invaded Ukraine. And in a couple of particularly brutal incidents, a maternity hospital was bombed. A group of parents with their children were bombed as well. And I wanted to pose this query: is that, and given our government's at support, certainly, or at the very least, seeming impartiality around what's happening in Ukraine currently, if the Russian government were to ask our government, to ask a university in South Africa to help them design a better navigation system for their drones. We have stellar universities in South Africa, some of the best electrical engineering departments in the world, in fact. What happens if they were to ask our universities to help design a better navigation system, for example, for a drone? Would that be something that our universities should query, should accept, should debate? And I think it's a really pertinent question to have perhaps just, and I don't have a simple answer for this, but to pose that and then move on to our discussion. So with that in mind, our first speaker is Dr. Kaimansri Moodley, who is a distinguished professor in the Department of Medicine and the director of the Center for Medical Ethics and Law, which is in the Faculty of Health Sciences, Stellenbosch University. The center was designated as a collaborating center in bioethics in 2019 by the WHO, and it's one of the 12 in the world and the very first on the African continent. She's also an adjunct professor in the Department of Social Medicine, University of North Carolina, Chapel Hill in the US. She's a specialist family physician, bioethicist, an NRF-rated researcher, and a member of the Academy of South African Scientists. To date, she's been awarded grants to the approximate value of 68 million rand. The center that she leads has trained 40 mid-career professionals from 10 African countries in bioethics, and currently has 2 PhD graduates and 6 PhD trainees. She serves on the Scientific Advisory Committee of the EDCTP, and her most recent NIH-funded research project explores ethical, legal, and social issues in data science innovation in Africa. And so over to you, Kaimansri. Thank you.
Thank you, Mark. And as you introduced me, I was thinking of the numerous conflicts of interest I must have myself. I always try to declare them. Can you please tell me if you can see my presentation on your side? It was up a minute ago.
Not yet.
It's disappeared.
No, it's not yet. I can't see anything just yet.
Yeah, I'll try and share it again, and just please confirm if you can see it.
It's loading now, Paul.
Loading. Okay. Thanks, Chanel. All good.
It is.
So you can see it on your side, but
Yes,
I can't.
Almost.
I can't see anything yet on my screen. But I think your introduction has
We've got
been
it. We
really,
can see it now. Prof. Moody,
Oh,
we
good.
can see it now.
Yeah. So it isn't showing up on my side. Well, it is. Can you definitely see it on your side, because there's nothing showing
Yes,
up
bro.
there?
Yes.
Yeah. Okay.
Got it.
So I'm not going to be able to see my slides, it would seem, because they aren't on my screen at all, although they were earlier. But I will proceed with the.
You've disappeared again, Prof. I don't know if you
that's
want me to try sharing it rather for you.
I think you should. Let me try one more time and tell me if you can see this now, Chanel.
I can see your screen, Prof. Yes.
Yeah. And the slides?
I see the slides, but they're not in presenter mode yet.
How about now?
Yes, perfect. I can see
Oh,
them now.
good. Okay.
Yes.
So I think we have to consider the entire research ecosystem if we have a discussion on conflict of interest. And there are conflicts that impact on research at various different points in the research cycle and on various different role players. You can see from this particular slide that nobody is really exempt from having some level of conflict where research is concerned. And many of the discussions revolve around funders and sponsors. And so very typically in medical research, we've had historically many examples of conflicts arising with respect to the pharmaceutical industry and other sponsors. But if we think about it, the challenge of a conflict of interest, spans the entire community in terms of research. And I will try and touch on some of these various aspects during the course of this presentation. Now, we all know that when we conduct research, we need to be compliant in terms of certain ethical rules, but also that research integrity is critical to the process. The Singapore Statement on Research Integrity, developed several years ago, specifically outlines conflict of interest and requires that in order for research integrity to be maintained, researchers should disclose financial and other conflicts of interest that may compromise the trustworthiness of their work. Proposals, publications, etc. And so you can see the conflict of interest spectrum ranges all the way through from designing a particular study to conducting it, but also through to the publication process itself. Now, the basic issues around conflicts of interest revolve around private interests intersecting with professional interests. And here, when we think of private interests, they relate to various relationships that we may have, family, friends, and others, but also financial interests and social interests. And the extent to which we allow these private interests to impact on our judgment, decisions, and actions in the work environment is important. And this is when we often experience some level of conflict if these two different types of interests conflict. Now, others have referred to these as primary interests versus secondary interests. And here we look at promoting, and protecting research integrity as a primary interest compared to considering other interests that may arise during the course of our work, be they financial, professional advancement, desire to favor family or friends, etc. And then, of course, conflicts may be real, potential, or perceived. So there is a level of nuance associated with understanding conflicts at various levels. And real conflicts arise when we cannot really pursue one interest without compromising another. A typical example would be a research ethics committee member whose father owns a company and has submitted a proposal to that research ethics committee where this particular member serves. Another way of looking at conflict is regarding it as only a potential conflict. And here we are often all in this position where we are involved in multiple different ventures. We have multiple interests. They may or may not come into conflict, but if we think they may come into conflict, then they are regarded as a potential conflict of interest. Examples here would be consultants providing technical advice to various companies, subsequently applying to do research in that field. So often when we join committees, etc., we are asked very specifically if we have interests that are related to a particular meeting. So various funders, the WHO, for example, may be having a meeting on antimicrobial resistance, and then will very specifically ask if members who are joining that working group have an interest in this field. And then, of course, there's just the perceived conflict of interest, where people may perceive someone to be compromised in a specific way because of friendships, for example, between researchers and REC members and various other such scenarios. Now, most commonly, there is discussion around financial conflicts of interest, but I have put up this slide to show the many other types of non-financial conflicts of interest that often come into play. And here, thinking very carefully, we need to consider research again through the entire life cycle of research itself. We often know that people may publish articles based on personal issues. We've seen recently an article published on COVID vaccines related to a cardiologist who has a very personal experience with his father who allegedly died after getting a COVID vaccine. And so when these sort of personal issues come into play, then the science is often queried. And the concept of bias becomes quite important. But many of these issues arise in the context of reviewing research articles. And often people will submit to a journal a list of reviewers they feel have a conflict of interest who should not be reviewing that particular paper. This could be related to enmities, it could be related to academic competition or rivalry, but these issues are extremely real and play out in the research setting from time to time. Having a personal relationship with someone who has a disease or condition under study that one is researching is another very interesting non-financial conflict of interest. Of course, there are other ethnic or cultural bias issues that also come into play. Now, many of these different types of conflicts were, arose in the context of the Jesse Gelsinger case in 1999 in the US, and I'm sure many of you are aware of this case. A young man with a disease called ornithine transcarbamylase deficiency, where his body could not process ammonia, and he had a genetic defect. There was an attempt to correct it by enrolling him in a clinical trial where a specific adenovirus vector was used to carry the genetic therapy into his body. Of course, the outcome was not good and he died, and there was a considerable investigation into this. So apart from a number of scientific issues that were questionable, apart from the consent process that was flawed in many respects, I think one of the major issues was related to the fact that one of the investigators had a financial interest in the company that was sponsoring the research. And we often, some of the organizations will ask us about financial conflicts of interest. The threshold used to be $10,000 US. It dropped to $5,000 US. But when we look at this particular case, the financial interest ran into millions of dollars, contested to be either around 13 million to 28 million US dollars, depending on when shares were sold in this particular company. So here the university was implicated, one of the researchers were implicated. It's a very, very interesting case study to look into in more detail. But for the purposes of this talk, I will limit it to that. There have been various studies conducted in terms of conflict of interest relating specifically to randomized clinical trials. And here we can see that research in itself carries the potential for a whole range of different types of conflicts, including how a trial is designed. clinical trials may use a comparator that is no less effective than the investigational product, and this may happen deliberately. The trial may be designed to produce a specific outcome simply because it is easier to achieve that outcome than the actual desired outcome that is needed for this particular trial design. There are many, many different ways in which there can be conflicts with respect to the contract between the pharmaceutical company or other sponsor and the researcher. And of course, it is the duty of a research ethics committee to actually interrogate these various potentials for conflict of interest quite thoroughly before protocols are reviewed. So science granting councils and research ethics committees play a very large role where conflict of interest is concerned. Of course, we are all asked to declare conflicts of interest, and disclosing conflicts of interest is important, but in and of itself is not sufficient to remove the conflict or to manage and deal with the conflict. Some institutions set up specific conflict of interest committees that interrogate issues where conflicts arise or have the potential to arise. And that is an ideal situation, when an institution can invest sufficient funding and resources into something as specific as a conflict of interest committee. Most often on committees, research ethics committees particularly, and science granting councils or other types of committees, recusal of a member is the standard where a conflict exists. However, this is not the only mechanism to deal with. There are many other ways of dealing with conflicts, including the need to amend one's role in a research project, for example, but various other aspects as well. So there are many different aspects related to conflict of interest from an ethical perspective and from a perspective of research integrity. In order to build trust in the scientific enterprise and in the research world, it is extremely important that there is transparency and that conflicts of interest are managed carefully. And of course, to ensure that the research results we produce are robust, objective, and trustworthy. I'm going to stop at this point, and I know there are 4 other speakers with extremely interesting aspects to discuss around conflict of interest, and hope that I've laid the basis or the foundation for discussing the ethical framework around this very important topic. So thank you very much for your attention. I hope I can stop presenting now and that I can return to the webinar.
Thanks, Brokmuli. Yes, you have. And thank you so much for really setting it up so nicely. That's just a lovely way to start in terms of all the issues to frame the discussions and the questions to follow. So thank you so much. And as I said at the beginning, we're going to wait until the end to have questions and that, just so that we don't, so we make sure we leave enough space for everyone. So I'm going to move immediately on to our next presentation. Our next presenter is Dr. Naveed Noor, who's an assistant professor of health policy and systems research at Aga Khan University in Pakistan. He's trained in anthropology and social medicine. He received a PhD in social research in health from the University of New South Wales, Sydney in Australia. He has contributed to a variety of academic and programmatic studies on HIV and other sexually transmitted infections, on health system dynamics, and conflict of interest arising from pharmaceutical incentivization in primary care settings. Dr. Noor is currently part of an international team that is exploring ways to reduce profit-led prescribing in Pakistan. So I'm going to hand over now to Dr. Noor. Thank you so much.
Thank you very much, Professor Mark Tomlinson, for the introduction, and good afternoon, everyone. I would like to first thank the Stellenbosch University team to organize. Could you see my PowerPoint? I lost it somehow.
We had
we could. Yeah.
They've disappeared again.
Yep.
Okay, it's back on again, Dr. Noor.
All right. Just a second. So I would like to first thank the Stellenbosch University team to organize this webinar on a very important issue of conflict of interest and how it plays out in global health, and for inviting me to present our research in the context of Pakistan. So to give you all a very brief background of the research project and our team. So our team investigates research on the issue of conflict of interest in a pluralistic health system, and this research is being collaboratively conducted by the Aga Khan University, Pakistan, and London School of Hygiene and Tropical Medicine. And there are several people who are contributing to this study, but mainly the research is being investigated by Dr. Mishal Khan, who is an associate professor at LSHTM and is the principal investigator of the project. Dr. Sadia Shakur, who is the principal investigator from AKU. She is an associate professor and a clinical microbiologist. Dr. Romina Hassan, myself, Dr. Samin, Dr. Rihanna, and Miss Afifa, who is from LSHTM. So this study is being conducted by a quite diverse and large team. And in today's agenda, I will be discussing my study background, study phases and methods, results, and a brief conclusion. So in terms of coming to the study background, I would like to start with the dynamics of Pakistani health system and then contextualize how pharmaceutical incentivization contributes to conflict of interest in medical practice and how incentivization to private general practitioners or GPs may affect quality of care in Pakistan. So Pakistani health system consists of public and private health sectors. And constitutionally, the federal and provincial governments are primarily responsible for health care provision. But factors like weak governance, poor resource allocation, and to the public sector, in combination with increasing population pressure and morbidities, they contribute to a greater dependency on the private health sector. That includes various small-scale primary healthcare clinics run by GPs, whom the pharmaceutical industry builds collaborations with to maximize profits. So we believe that the pharmaceutical industry is often a vital source of information. And certainly, I think GPs or physicians, they can benefit a lot from that information in terms of taking informed choices and decisions in relation to patients' diverse health needs. However, the relationship between pharmaceutical companies and GPs can negatively affect patients' health and well-being when incentives are mobilized to maximize profits through inappropriate prescribing. So as a result of pharmaceutical incentivizations, GPs may experience a conflict of interest, a situation where GP's professional judgment is influenced by a secondary interest, such as a financial gain, that leads to a decision that conflicts with their interpretation of patients' best interest. And there is strong evidence that GPs who engage with pharmaceutical incentivization are likely prescribe unnecessary or more expensive medicine to patients. That contributes to an increased financial burden on them. And also, I think pharmaceutical incentivization has important implications for antimicrobial resistance as well. Because to achieve pharmaceutical targets, GPs may prescribe antibiotics to patients with common self-resolving ailments like cold and flu. So because pharmaceutical marketing through financial incentivization of GPs is a poorly studied health system problem in Pakistan, we are in the process of conducting a multi-phased study to investigate this problem. So our research is being conducted in three basic phases: a formative phase, an intervention phase, and an evaluation phase. And we have 4 research questions to deal with. The first 2 questions, we are trying to attempt to answer them through the formative phase. That includes a qualitative investigation, qualitative interviewing with GPs, with some policy actors, with some pharmaceutical sales representatives. And we also conducted a survey on GPs' knowledge and attitudes in relation to conflict of interest in medical practice. So we also took advantage of this phase in terms of co-developing an intervention to see what could work for GPs to adopt ethical practices. And I think based on what we have found from the formative phase, we have developed a multifaceted intervention, which we tested through a randomized control trial. in which a set of GPs belonging to the intervention group received some seminars, some very emotive seminars on medical ethics, while the control group GPs received some seminars on basic topics, clinical topics like thalassemia, how to manage thalassemia and anemia in primary care settings. So we have already conducted our intervention phase, and now we are in the process of evaluating the impact of the intervention, because we have 3 outcome measures, namely knowledge, attitude, and practices of GPs in relation to conflict of interest arising from pharmaceutical incentivization. And to assess this, we are conducting an online survey on GPs' knowledge and attitude. And also we have developed a very novel method of measuring the impact of the intervention on GP practices through a standardized pharmaceutical sales representatives method, which we call SPSR method, in which we trained several researchers to act like pharmaceutical representatives, and we send them out to GP clinics and offer GP some incentives. And this is how we sort of attempted to assess the impact of the intervention. So I think I will not talk much about the intervention phase, because we still are in the process of collecting some data and analyzing it. Mainly in this presentation, I'll be talking about the results that we have achieved from the formative phase. So I think the results that we have gotten from the formative phase, I have classified them into 3 themes. What incentive types do GP receive from pharmaceutical companies, the factors that lead to pharmaceutical incentivization, and then implications on patients' health and well-being. So in terms of what incentives GP get from pharmaceutical companies, we found that GPs are usually offered and take a range of incentives from pharmaceutical companies and prescribe medicine to meet pharmaceutical sales targets. And this process is often mediated by pharmacists who act as brokers between pharmaceutical sales representatives and GPs, as they not only share profit with GPs from the sales of medicines, but also provide sales representatives with information on GP prescribing practices, their relationship with other companies, and resources that GPs may require from pharmaceutical companies. So pharmaceutical sales representatives gave GPs access to a range of resources like money, items for personal, professional, and family use. And they also sponsored some educational events in return. GPs benefited pharmaceutical companies by prescribing their products. So in terms of financial resources, it was quite straightforward. It was money in the form of cash or check. And then there were several material resources that pharmaceutical companies can generally give to GPs. They could include things for clinical use like ECG machine, BP operators, and other clinical equipment, and sometimes items for renovating clinics like furniture and renovating homes. And there could be some items that could be of GP's personal use, for example, a nice car, a mobile phone, a laptop, something like that. And there were also some resources for family events as well, for example, for birthdays, for funerals, for weddings. So there was quite a diversity in terms of the resources that GPs usually get from pharmaceutical companies in return for prescribing. So pharmaceutical companies also gave GPs academic resources like books, journal subscriptions, and also sponsoring academic conferences, which could be locally, which could be held internationally, and also, of course, recreation, funding them to get their families to some sort of resort and have some good time. So I think the important thing in this context was that many sales representatives justified the donation of clinical equipment, books, and sponsorship to attend educational events because they believed that these resources can increase the capacity of doctors and improve quality of care for patients. So we also explored factors that sort of contribute to this problem of pharmaceutical incentivization to GPs. And we have attempted to classify them to tease out factors at different levels. So if we look at factors at micro level or a very individual level, I think honesty, integrity, health promotion, friendliness, sincerity with patients are generally seen to be elements that constitute GPs' moral commitment in good medical practice. And I think a poor physician may not be only characterized by inadequate knowledge or skills in medicine, but also in terms of possessing some negative tendencies and intentions, which may not be in patients' best interest. And our data, I think, gives a clear indication of how private GPs in Pakistan often give more importance to money. And this profit-making mindset generates the desire to obtain extra resources from pharmaceutical companies, and this may happen at the expense of patients' health and well-being. So in terms of meso level factors, or maybe the interpersonal level factors, GPs who might not get a chance to receive a postgraduate qualification might end up doing a general practice in private small scale clinics where income generation might be limited. At the same time, increasing family needs in combination with the socially desired standard of living might lead them to co-generate incomes or resources from pharmaceutical companies. So both micro and interpersonal level factors work together with market-related conditions as well, which we think could be the exo factors. So pharmaceutical companies' market dynamics indicate conditions which apparently seem external to GP practice, but may indirectly exert influence on their prescribing practices. For instance, the growing competition between local pharmaceutical market, between local pharmaceutical companies, makes space for mobilization of incentives to secure GP support to enhance pharmaceutical sales. So all these things work together very much with macro level factors that include, health regulation, policies, and guidelines. So health regulation involves safeguarding people's health and well-being by detecting and addressing malpractice within the healthcare system through laws, policies, and their implementation. But in Pakistan, the diverse mandates possessed by federal and provincial regulatory bodies, together with institutional corruption, sometimes make it difficult to perform health regulation, and hence the competing centers of power may dilute the centrality of the health system, which further contributes to the constrained regulation of the pharmaceutical industry and GPs. So I think all these factors, micro, meso, exo, and macro, they work together and produce a context where GPs and pharmaceutical companies, they find a perfect ground to mobilize incentives to generate maximum profits. So in terms of the implications for patients' health and well-being, I think so far we have been able to tease out two sort of consequences that could happen to patients, which is patients' exploitation, financial exploitation, I would say, and giving them unnecessary medications, which has implications for negative health outcomes. So once pharmaceutical incentivization happens due to a combination of factors such as weak health regulation, competition in the pharmaceutical market, and other individual and interpersonal level influences, it generates some negative consequences for patients' health and well-being. On the one hand, a lack of awareness among patients about health and illness can make it easier for GPs to exploit them with incentive-driven prescribing. And on the other hand, unnecessary medications may not only put patients under financial burden, but also it has some implications in terms of antimicrobial resistance if antibiotics are given unnecessarily. Hence, pharmaceutical incentivization can compromise patients' physical and social well-being. I'll quickly move on to the just final slide, and I think I'm running maybe out of time. Okay, so the most important aspect of our study is the exposition of the absence of quality of care parameters and how this allows GPs to give primacy to personal gains over patients' best interest. And we should also acknowledge that in Pakistan, the private health sector plays a very crucial role in delivering healthcare to almost 80% of the population. And I think the practice of incentive-driven prescribing implies that the distortion of GP's prescriptions can affect a large proportion of population, and hence achieving good quality of care can continue to be a problem unless profit-led prescribing is addressed. And I think this goal could be achieved through providing continued formal education on medical ethics and quality of care, and certainly I think strengthening health regulation. So I think the problem of profit-led prescribing could be addressed, although it's a very complicated problem. Thank you very much for that. I'll be happy to take questions if you have any.
Thanks so much, Dr. Noor. Yeah, absolutely fascinating research, and yeah, thank you so much. As I said at the beginning, do we have anybody with any questions quickly for clarification or any points to be made? Because Dr. Noor has to leave before we have our question time. So if you want to hold up your hands, I will field them or put the question in the chat. Or if anyone obviously wants to email Dr. Noor as well, you can see his email there. And I think just there was one question about it. This webinar is being recorded and will be made available. So anybody wants to, get the email then as well. So I'm not seeing any right now. No, so not at the moment, but thank you. Thanks so much, Dr. Noor, for your fascinating presentation. And yeah, wish you well with the research.
Thank you very much. Thanks.
All right. Thank you so much. So I'm now going to move on to our next speaker, which is Professor Tanya Doherty, who I've known for many years, used to work with her at the Health Systems Research Unit at the South African Medical Research Council, where she still works. She's a chief specialist scientist there. Her research focus is health system requirements for the optimal delivery of priority child health programs at community and primary care. She has conducted several cluster randomized trials and program evaluations of community and primary services in South Africa, and has published over 100 peer-reviewed articles. She's also an honorary professor in the School of Public Health at the University of Western Cape, where she teaches and assists with student supervision. And she's done a substantive work on the issue of breastfeeding and on formula milk influences. And so I'll hand over now to you, Prof. Doherty. Thank you.
Thank you very much, Mark, and it's a pleasure to be part of this important webinar this afternoon. Can everybody hear me and see the slides okay?
Yes.
Yep,
Great.
got them.
As Mark said, I'm going to be talking on the issue of marketing of commercial milk formula and the influence that it has on health professionals, and looking at what we can do about this and why this is an important issue. Okay. So the feeding practices of children are important. In the first 3 years of life, the way children are fed profoundly affects their health, their development, and their survival. And there are enormous health benefits of breastfeeding to women as well. And so decisions about infant feeding should really be based on the very best information, on accurate evidence, and influenced only by what is best for the parents and the child. And the decisions about infant feeding should be free from commercial interests. It's been estimated that the economic cost of not breastfeeding, according to WHO recommendations, for South Africa is around $2.2 billion, and globally around $341 billion are lost due to suboptimal breastfeeding practices. So this figure on the top left shows trends in per capita formula sales for 190 countries. And between 2005 and 2019, the sales of standard, follow-on, growing up and special formulas increased from 64% for the standard milks up to 214%. Whilst over the same period, the figure on the right shows that in 83 low and middle income countries, there have been marginal improvements in exclusive breastfeeding, with only a 25% improvement over this time period. So more children today in all regions of the world are consuming formula milk than ever before. Now, there are many reasons why women may choose not to breastfeed, and these could include a personal preference, work constraints, inadequate access to maternity protection, perceived insufficiency of breast milk, societal norms, and importantly, poor support from the healthcare system. But the marketing of formula milk products represents one of the most underappreciated influences on women's decision-making. So in 1981, the International Code of Marketing of Breast Milk Substitutes was adopted to try and regulate marketing of these products, and it included specific provisions to protect health professionals from inappropriate engagement by industry. But 40 years on, the marketing of formula milk remains widespread and aggressive. And not surprisingly, this is driven by finances. So in 2019, annual sales of formula milk products were estimated to be around $55 billion US. And companies invest around 5 to 10% of these annual sales in marketing, and this amounts to around $3 to $5 billion per year. And so to put this in perspective, the operating budget of the WHO for a 2-year period was around 5.8 billion. So this is similar to the amount that formula milk companies spend annually on marketing. And so this enormous budget gives these industries huge power and sustained influence. In South Africa, we have what's known as the R991 regulations, which are designed to restrict the marketing of designated products to children under the age of 3 years. And these regulations enact the Code of Marketing in South Africa. I'd like to share with you some findings from a recently published WHO Unicef multi-country study undertaken in 8 countries, one of which was South Africa. And this study included interviews with pregnant women and women with children under the age of 18 months, as well as interviews with health professionals in both the public and the private sectors. And what the study found was that formula milk marketing is ubiquitous and takes many different forms. The multiple channels and approaches used include traditional advertising, free samples, promotions and gifts, advertising through social media platforms and particularly through digital influencers, conferences, talks and events, as well as political lobbying, including to influence the international regulatory processes. Health professional targeting is one major part of industry marketing, and in South Africa, almost half of the health professionals interviewed reported that they had been directly contacted by a company representative at their place of work. Several of the health professionals stated that they recommend the brands that they had received information about from company representatives, or that their hospital was sponsored by a particular brand, and so they recommended that formula. And so these findings you can see are strongly aligned to what we've just heard in relation to the pharmaceutical industry, and many of the tactics and approaches are very similar. More than a quarter of health professionals had been invited to and had attended an event sponsored by a formula product company. So the marketing directly to health professionals takes the form of sponsorship of stands at conferences where they have high visibility presence. They give out free gifts and sponsor breakfasts, lunches, dinners. There's quite significant training opportunities which the companies offer to health professionals, and in particular these so-called nutrition institutes, the Nestle Nutrition Institute. Other companies also have institutes which really offer training under the guise of often and accompanied by advertising as well. Research is also often funded, particularly research on infant nutrition is often funded by industry, and they have paid adverts often in scientific journals. The two examples that I'm showing here are from the most prestigious journal globally, Nature. Nature accepts paid adverts from formula milk companies, and they are called advertorials to give the impression that they have some scientific legitimacy, but they're actually paid adverts. And they give the impression that these articles are about breastfeeding or breast milk, but actually they're advertising the new components, including human milk oligosaccharides, in their formula milk products. So misleading scientific claims was found to be a dominant theme in the research, including the use of scientific imagery, language, and pseudoscientific claims. Products are positioned as being close to, equivalent, and sometimes even superior to breast milk, and scientific evidence is misused to infer improved health outcomes. There's a huge range of new products that focus on allergies and sensitivities, and this is a major area for sales and business growth. In terms of influencing policy, in South Africa in 2012, we had a major event which led to the Tanya Declaration of Support for Breastfeeding, in which South Africa committed to protect and support breastfeeding. Very soon after this event was held, Nestle hired a consulting company to do a stakeholder mapping exercise to identify people in the national government, in academia, and in civil society that they felt they could, as they term it, retain and reward for being champions of their products. And these include, people like Linda Richter and, prominent academics in the nutrition and child health sphere. So I just want to share some of the qualitative research that was undertaken amongst health professionals. Here is a quote from a private GP who said she sees the formula reps a lot. She sees 3 of them. They tell her all the latest things. She has millions of pamphlets, and they push their products through me. A nurse in a private hospital in Cape Town said Nestle would come and give in-service training on their new products every 4 to 6 months about the new type of NAN, the added benefits, and how it affects the gut. And this regular contact of health professionals with industry was found to really influence their own understanding and perceptions of breast milk, of breastfeeding, and of the equivalence of breast milk to formula milk. As this nurse said, what we're telling them, in this case mothers, is nowadays there are formulas that are made really exactly like breast milk. And another nurse said the formulas are very close to having ingredients that are found in breast milk, that they have the same amount of nutrients, and the formulas have gone that far. So this was a dominant theme in the research, really, that the influence on health professionals and their own perceptions and understanding of nutrition and breastfeeding have been significantly altered. In terms of the newer types of formulas, the marketing messages really are exploiting mothers' insecurities and their own sense of ability to satisfy and calm their infants by framing absolutely normal neonatal behaviors as pathological. And as this GP explains, we have a rep that comes and tells us about Novolac, the one for colic, the one for diarrhea, for regurgitation, for crying, for gas, for constipation. There's something for every type of baby. So absolutely normal newborn health issues in crying, gas is framed as being pathological, and that formula is the solution. So what does this mean for individual health professionals? So we are all influenced by marketing in our daily lives. And in the public health arena, we have a strong body of evidence of the impact of marketing, particularly around sugar-sweetened beverages, alcohol, gambling, and now infant formula products. And the problem is the marketing practices of these industries. It's not the availability of formula products in supermarkets, and it's not the choices of women or families. It's about the marketing practices. So the tactics and the relationships with industry, including financial or material support, sponsorship of training or research, advertising in journals or at events, these all contribute to conflicts of interest within health professionals and within the health system. And this creates a bias whereby, as health professionals, we may consciously or unconsciously favor companies in ways that may undermine clinical judgment. And this means that we may breach obligations to the health and well-being of patients. And it may influence our own understanding and our decision-making and the support that we provide to families and women. So why is this an important topic? Well, formula milk marketing impacts the survival, health, and development of children and women. It disrupts access to impartial and truthful information and support, and the right of parents to make decisions that are not unduly influenced. And this is a right enshrined in the Convention on the Rights of the Child. It disregards the International Code of Marketing, which is the collective will of the member states of the World Health Assembly. And it exploits aspirations, vulnerabilities, and fears at the time of birth and the early years of children's lives for commercial gain. So we know that health professionals, individually as well as through their associations, are a key target and an asset in the marketing strategies of formula companies. So how can we, as trusted and influential professionals, protect and prioritize child health over shareholder benefits? So firstly, we need to sensitize health professionals to the code in both pre-service and in-service settings. We need to explicitly reject marketing in our healthcare settings. We need to correct misconceptions about the equivalence of formula milk to breastfeeding and breast milk. And we should be speaking out against misleading pseudoscience and not be accepting funding from the formula milk industry. So we think we can remain unaffected by marketing, but we're wrong. Marketing does work. We know we have plenty of evidence to show that marketing works and that it can change our behaviors in ways that we ourselves cannot always judge. And being amongst the most trusted members of society as health professionals, this gives us enormous influence, and the formula industry knows this and capitalizes on it. So as health professionals, as associations, as academic institutions, we should be adopting, publicizing, and implementing strong conflict of interest policies to impede corporate interests from influencing critical health guidance, practice, and training on infant and young child feeding. Thank you.
Thank you so much, Tanya. Fantastic. Yeah. And also a sort of a similar webinar was happening simultaneously with this, organized by WHO. And thank you, Tanya, for choosing this one. So just fantastic. I'm going to move rapidly on to our next speaker, which is, sorry, let me just call up which is Dr. Chantel Witten, who's a registered dietitian with a PhD from the Center of Excellence for Nutrition at the Northwest University. She has more than 20 years of public health nutrition experience that spans across several sectors, most notably academia, the UN, and the NGO sector, both nationally and internationally. She serves on several technical advisory groups to advance the child nutrition agenda in South Africa. And she currently leads the Infant and Young Child Feeding Advocacy Project for the DSI NRF Center of Excellence for Food Security, which is co-hosted by the University of the Western Cape and the University of Pretoria. and she's an advocate for children's right to food and nutrition. And anyone who's done work in this area will probably know Chantal really well. So over to you, Chantal. Thank you. Chantal, you may be muted. I don't know. We can't hear.
Apologies.
There we go. Can hear you now.
I'm going to share my slides. Hopefully this opens up to my slides.
We did see them just now, yeah, so they were there. Yeah.
Oh gosh. I can't seem to find them. Oh, sorry about this. Can I just put up my camera? I think it has
Sure.
I think it has something to do with the camera. Thanks.
Yeah, cool.
Mark, can you see it?
No, it looks like we've got a picture of your screen with the, with all the people's names on the webinar.
I'm not understanding why it's not showing the slides.
You probably clicked on sharing the screen and then you've got to choose the correct one. That's what probably has happened. Does Chanel have a copy of your version of your slides? Perhaps we could do it. There we go. I can see that.
See it
yes,
now?
Got that.
Yeah,
There we
okay.
go. Perfect. Yeah.
Apologies.
Yeah.
Apologies, everybody. So I'm going to be presenting from the advocacy project that I'm currently leading, and we're focusing on industry influence and interference. And in keeping with the theme of nothing is free, I'd like to focus on the real cost of free lunch. I have no conflict of interest to declare. I've received no incentive to participate in this event. And my interest is in universal child rights with a focus on infant and young child nutrition, and particularly engaging so that we can build networks and coalition towards putting children central to development. The outline of my presentation is going to look at the long-standing relationship of the infant formula industry and academia, the South African academic landscape and industry at current, what we know about it, and then through the advocacy project that we are working on, the call to action for academic institutions, and particularly on the training of health and development professionals. So I thought let's start with what is free lunch. And it says that in economics, there is no free lunch in economic terms, and that everything comes with a price. And in fact, in South Africa, we have a very nice expression. We say nothing for mahala, which means nothing for nothing. And therefore, the price may not always be in money, but if you get something for free, there is a cost that has been paid somewhere in the wider economic system. And so if we are talking about getting freebies and getting free support from the formula industry, who is paying that cost? And we know that children are currently paying that cost. Children's lives, Professor Doherty showed what is the impact on children as well as on women's lives. And it casts a long shadow for children, that they're not only paying now, but they're also paying in the future, because we know that the non-communicable diseases profile of South African children is dismal, and in the future they're going to be carrying that disease profile too. So I've been engaging with a number of formula industry representatives and leadership, and every time I have this discussion, it comes up that actually in the formula industry world, they're not displacing breastfeeding. They talk about increasing market share. So if we think one company A is taking the market share from company B, how is it possible that we can have projections of increased formula sales? And Tanya also showed very nicely how those formula sales are increasing against a very stagnant breastfeeding curve. And so that actually means that it is coming at the expense of breastfeeding. So you cannot be increasing your sales if you are not getting more women to move towards formula. So if we talk about the interaction with academia, I found this article which was published in 1987, but it reads, the infant formula industry and and the academic community have developed and maintained significant educational and research interactions over the past 4 decades. So if you take before the publication, that means 40 years before 87, early 40s, that relationship was already established. Furthermore, we know that this publication that came out in 1987 was after the code that was instituted. And again, as Tanya showed earlier, very prominent, very leading academic publications have this relationship and are actually engaged in different ways with formula companies. Tanya also picked up on this report, which came out in 2012. A colleague of ours, Laurie Lake, happened to find this report very late in 2016. In the industry circles, this report was done way before the regulations actually came out. The regulations in South Africa came out the 6th of December 2012, and this particular mapping exercise was done already early 2012. And you can see here in the Sahara SALT report, it shows that science and academic institutions were already understood to influence government agenda. So for the scientists and for the academics, this is not about your publications or about building your image or the, let's call it, the endorsement of the industry, which has been seen favorably. So in the early first round, academics associated with industry were always seen as the top academics. They were seen as the thought leaders, the groundbreakers. But the reality for the industry, it was never about the academic agenda. It was really about using academics as a conduit to get to government, because academics are actually seen as the knowledge brokers and the knowledge generators. From that same report, we find that there's something called the echo chamber, and it shows very clearly that by influencing the academic and scientific arena, we would, as the industry, it would filter and flow into the professional organizations, and those professional organizations are used as educational conduits, as influencers for healthcare professionals. And healthcare professionals, in the end, actually are influencing consumers. So very strategic, very intentional. It was not that industry picked and choose who are the influencers. They targeted down and buckled down on the scientific institutions and scientific individuals, because the long term, the long view was about influencing government. So in South Africa, we had the regulations that Tanya referred to, and the regulations had specific, sub clauses that catered particularly about how industry had and how we had understood industry to be engaging with the scientific community and with health professionals. And in sub-clause 7, you have a number of very distinct talking to advertisements and talking to publications. It talked again about the donations and the distribution of material support to institutions, research grants, and any other financial assistance. And usually these are fronted by what we call private INGOs or international NGOs, PINGOs, something like the Nestle Nutrition Institute Africa. So it would offer bursaries, scholarships, exchange programs, sponsorship of the conferences, learning opportunities, exchange programs again, and then also sponsorship of meetings that were particularly targeting healthcare professionals. Not only just in the healthcare arena, but we've seen this now being expanded to child development and early childhood fraternity. So while we are focusing on the health professionals, the industry has already expanded beyond health professionals. So Tanya showed a very nice slide where it actually listed the individuals that the industry had thought about and the industry had targeted and had kept them in a category called retain and reward. And that was back in 2012. I'm using this slide to demonstrate the long vision of that. We see that in 2015, the first Doherty conference was held on African soil. It was hosted in Cape Town. And we see that the platinum sponsors for this particular event was actually Nestle and Danone. And in discussing about how was it that these two, what we would see as competing industry players, were actually on the same platform, I was told when there's no conflict. And so I think the playbook that we are talking about is about strategic and intentional manipulation of health professionals. And we see that this played out long after the regulations were in place. In South Africa, we had last year a very disturbing development that one of the directors of the Arua Center of Excellence for Sustainable Food Systems, hosted by the University of Pretoria, was appointed to the board of Nestle. And that happened even though we have the regulations, even though we have, again, a very active academic and health professional societies in South Africa who look out for these kind of conflicts of interest. We saw that this, even though there was a lot of efforts made by civil society and a number of institutions to bring this to the attention not only of our government, but also internationally, we were not able to have any traction because the particular academic is not a health professional. And so therefore the reach of our regulations R999 was not able to actually counteract this. Also, in terms of the public, I take this quote that came from one of the submissions on the concern letter. It says, academia is seen as the thought leaders and the generators of knowledge. We can't allow industry capture. The public trusts us. And that's exactly what the industry values and exploits, is that the industry knows that academics and academic institutions are trusted sources. And therefore this association with academics and academic institutions actually buys consumer trust, public trust. So academics are part of the system, and I take this quote from Professor Amy Brown, who says, no woman fails to breastfeed. They fail by a system that fails to support them, both during breastfeeding and when they cannot. And this is exactly the exploitation that the formula industry is using. Academics are by extension the formula industry, and academics, I don't think, are oblivious to this. We know that our consumers and our users of healthcare services actually value us. And so if we are going to be building counteractions against industry influence and interference, we need the following to happen rapidly, is to create awareness and raise alarm bells at every incident or incidents of industry engagement, and there are many that are happening. Dr. Noor showed a continuum of how industry is engaging with academics and academic institutions. We must call on as individuals, even sitting in this webinar, we should be calling on our academic institutions to have structures and processes in place that actually regulate industry engagement, especially around the training of health and development professionals. And then we also need active monitoring and proactive academic citizenship to promote, protect, and support breastfeeding as a cornerstone. The evidence is there, and therefore we should not be talking about breastfeeding or formula feeding as a replacement. It's not equal to breastfeeding, and we need to start changing that language, as Tanya had pointed out. And then just to remind us all, if we are accepting free lunches, then we have to remember he who feeds you controls you. And that is something that we must guard against as academics and as researchers. Thank you very much, Mark. Over to you.
Thanks so much, Chantal. Yeah, I'm finding all of these presentations simply fascinating, and the further we go, further I hear all these, I'm so struck by the level of work that we are going to have to do to shift things, to make authorities and universities and elsewhere aware of what's happening, both subtly and as you've shown in many cases not so subtly. I'm quickly going to move on to our final speaker, who is Professor David Ross, who's a clinically trained epidemiologist who's done research, currently doing research and training related to adolescent health and well-being. He, in fact, is an extraordinary professor extraordinary in epidemiology and public health at Stellenbosch University, part of our institute. He's currently a part-time consultant to the Child Health Initiative of the FIA Foundation. He's seconded to the Partnership for Maternal, Newborn and Child Health to work on the technical underpinnings for a global forum for adolescence planned for October 2023. From 2015 to 2020, he led the World Health Organization's work on adolescent health research and guideline development, which was where I met him at that time. Prior to that, he spent 32 years on the academic staff of the London School of Hygiene and Tropical Medicine, during which he spent 10 years based in Africa in countries like Ethiopia, Sudan, Ghana, and Tanzania, and did research on child and adolescent health. And so over to you, David. Thank you.
Great. Thank you very much indeed, Mark. So I'm going to talk a bit about from my experience of working in WHO and before that as an academic related to declarations of interest and potential conflict of interest within the WHO. And I'm going to start by just saying that the declarations of interest and the potential for there being conflict of interest in the advice that WHO receives or among the staff of its own institution is very important because WHO is expected to provide unbiased, evidence-informed guidance, and the whole of the organization's reputation depends upon this. So it is actually taken extremely seriously within WHO, and this is for multiple reasons, because WHO guidance may result in substantial investment or disinvestment in products or services globally, medications, vaccines, equipment, technical support even. Or if you're on the International Health Regulations Advisory Group, it could result in a declaration of a public health emergency of international concern, which, as we saw with the Ebola epidemic in West Africa, may have devastating economic and other effects on a country or on a group of countries, or even on all the countries of the world. Next slide, please. So it is taken very seriously, and each year every staff member must complete a declaration of interest, and for every meeting or document that is produced by WHO, experts that contribute to that, you have to fill out a similar form. It's just over 3 pages long, and it has to be completed by the experts at every meeting. So if you have a series of meetings, for example, on a guideline development group, they have to fill out a form for every meeting in case something has changed. And it explicitly states that they must declare any interest that may affect or may reasonably be perceived to affect the expert's objectivity and independence. As well as their own interests, they must declare any relevant interest of their spouse, their partner, or their children, and, for example, any close professional contact or friend. The friend part is a bit vaguer, and it really has to be if that friend is going to influence your potential for objectivity. Next slide, please. So what does this actually include, this form? It actually has, as well as an overarching kind of question for anything else that's relevant that comes towards the end, it specifically asks about this list here. employment and consulting that you have that could influence your objectivity, research support that you've received, investments that you have of any kind, intellectual property where that this could be influenced by a decision that comes out of the group that you're or consultation you're attending, any public statements or positions that you've made of relevance to the topic of the meeting or the document, whether you've worked for a competitor of a product that's being considered, any benefit that you might get from the outcome, any travel costs that you've received from anybody except WHO to attend the meeting. So have you been sponsored to attend the meeting by somebody, basically? Have you received any payments for speaking about the topics that are going to be considered at the meeting? And then there's, because of historical reasons, there's a particular section about any contacts or connections that you have to the tobacco industry. And when I'm talking about you, I'm always meaning the expert or the staff member or their spouse or their partner or their child. Next slide, please. So what then happens if the expert fills out that declaration of interest? A WHO staff member, usually the person who's holding the meeting or going to be responsible for the document, assesses all the interests that have been declared and decides either that there's no potential conflict of interest exists, or there is one, but it's actually irrelevant to the context of the meeting, or it's insignificant, it's not likely to be important, in which case no action needs to be taken. And no statement needs to be made about that, because sometimes people do put things on their form which actually are not, they really are considered to be insignificant. But of course, that's a subjective judgment. Or that there is a potential conflict of interest, but that is potentially one which allows the person to fully participate in the meeting as long as they make a public disclosure of their interest, so that everybody involved can know that they have that interest. Or that they need to be partially excluded from the meeting or the part of the document that's referring to the particular area where they have an interest or a potential conflict. And so they would be asked to leave the room when that's being discussed, or if it's in any report, they have no say on that part of the report. Or totally excluded from the whole process, be it a meeting or the development of the document. I think a thing which only came in a few years ago is that all the declaration of interests must also be made at the start of a meeting and must be published in the meeting report so that people can see them and know about them actively. Next slide, please. So I know time is short, so I'm just going to give a couple of examples. These are real examples. So back in 2000, I was invited to a meeting. It was a consultation on the effectiveness of biomedical HIV prevention strategies. And I needed to decide, should I declare that I had a research grant on whether vaginal microbicide, a particular vaginal microbicide, prevents HIV in women? I thought and did declare it, so yes. And I think the right thing, having thought about this when the boot was on the other foot, was that I liked people to declare if they were in doubt. And the decision that was taken by the WHO staff member at that time was that yes, the declaration should be made, including verbally to all the participants, but that there was no exclusion needed at the meeting. So I could fully participate in all the discussions and the conclusions arising from them. A more recent example, I guess actually this wasn't 2022, it was actually 2017-18, was the guideline development group on psychosocial interventions to promote adolescent mental health and prevent common mental disorders in adolescents. This is actually not a true case. This is one which I've invented. But should I have declared, if it was me who's the expert, that my son works for a tobacco company? He doesn't, but should I have declared that if I was an expert attending the meeting? And the answer is unequivocal in terms of WHO guidance. The answer is always yes. And the form actually states that you must answer that question without regard to the relevance to the subject of the meeting or the work. That's specific to tobacco. I personally, this is a personal opinion, think that ought to apply to a few other things, and we've heard about the breast milk substitutes as one potential, but it doesn't currently, unless it's relevant to the topic of the meeting or the document. Whereas for tobacco, it's anything. So the action that would be taken by somebody if this had happened would be that one would actually, if you're a sensible staff member, you would do a quick check with the legal department of WHO, but that would be extremely likely. In fact, it would lead to total exclusion from the consultation, or the guideline development group in this case. So in reality, what did I observe when I was at WHO? First, the system almost entirely depends on the honesty of the person completing the form and the completeness of the information that they provide. So it's not going to catch people who are deliberately wanting to hide a conflict of interest. For that, one is going to have inside information and potentially to be tipped off by somebody. And the vast majority of staff and of experts actually declare no relevant interests. But should many actually really declare something? For example, in particular, often for academics, it's relevant research support. I think that they should, even if it's not going to lead to any action, or potential benefit from the outcome of the meeting, for example, related to their own research group or their own research findings being given more prominence, because at these consultations WHO wants the people who know the most about it, but I think that these interests should be declared, even if they would be judged by the WHO staff member not to be significant or a relevant conflict of interest, or to be one which could be declared, but no exclusion would be required. Those are just a few thoughts. Handing back to you, Mark.
Thank you so much, David. Yeah, lovely way to end the meeting and to see the process in practice. As tends to happen, we've run short of time. But I'm going to ask if there's any burning questions, comments that anybody would like to throw out there. Put up your hands. As I said, this webinar will be has been recorded and will be shared. So yeah, and feel free, if you want to get in contact with any of the speakers, you can email me or Chanel, and we can put you in touch. Any questions, comments that people might have, bearing in mind it's very late and yeah, we've only got 2 minutes left. And thanks, Chanel. Chanel's just shared the link for kind of previous webinars as well. So thanks, Chanel. It doesn't seem like, wait, David, would you like to jump in there?
Well, just one other conflict that I've noticed is where a clinician has an interest or an actual sort of ownership of the pharmacy next door. And I think that's an area which also needs to be thought about very carefully, because obviously the tendency would be to get profit from prescribing more, but also directing people towards that particular pharmacy rather than another one.
Totally. Yeah, couldn't agree more. Absolutely. Thanks, David. Leslie London, would like to jump in.
Thanks, Mark. It was a great seminar, and I've been posting stuff in the chat, and I just want to alert people to a project that, in fact, Comento is a collaborator on, which is basically addressing the problem that people don't really identify conflict of interest when they're in positions where they need to. And so we have a grant from the IDRC developing materials for ethics committees and science granting councils to be able to empower them to better manage conflict of interest. Those materials will be made publicly available. There'll be a short course and a toolkit, and we're busy sort of finalizing that. I'll be happy to present it at a future meeting. Commentary, Mark Blockman and colleagues from Cameroon and Kenya and American University of Beirut are working on that. Thanks.
Thanks, Leslie. We'll definitely be in touch. I mean, I think we would like to have a series and to continue this conversation, because I think you're right. It's it took me quite a while to realize at WHO guideline meeting that things that I thought were innocent grants, I did actually need to declare, and then it was up to the group to decide. It wasn't me deciding on my conflicts, it was declaring it, as David so aptly showed. Laurie, did you have a comment? I see something from you in the chat. Laurie Lake?
Yeah,
yep.
I just felt like a lot of what we've been discussing so far is about the individual and a conflict of interest related to the individual's relationship or funding streams. But we also need to be looking at universities as institutions. We need to be looking at things like donations, offers of funding, significant research and teaching programs. And the question is, who is monitoring that? Is it the ethics committees? And to what extent are all ethics committees equipped to appreciate the conflicts of interest that exist, for example, within health? So if you have someone who's heading up an ethics committee who's in engineering, they don't have the grounding to understand the sort of complex web of influence that exists, for example, linked to the tobacco industry or the formula industry. So the kind of work that Leslie is doing, I think, is really, really important in strengthening the institutional framework that would allow us to better ensure accountability and transparency. And I suppose what was so, for me, distressing around the situation at the Centre of Excellence in Food Security, the Arua Centre of Excellence, is to have a person in, leadership position in an institution that's responsible for food security for the region, taking on a position on the Nestle Global Board, which is heavily remunerated, maybe more than sort of 6 million rand a year. And for the University of Pretoria to say it was sufficient that she had declared that position, and they saw no conflict of interest. They saw no fundamental conflict. They were simply interested in the tick box exercise. So we need to do a lot more to strengthen our systems.
Thank you, Laurie. I mean, I think that's such an important point, that this is not just about individuals, but it is institutions. And I think increasingly in that corporatization, we have to be very cautious. Today, as many of you know, the Treasury banned Bain and Company, the consulting firm, from doing business with Treasury for the next 10 years because of their activities during with the Guptas and others. And often these faculties, and we're talking from the Faculty of Health and Medicine, but often faculties are incredibly siloed. And so I don't know if there's a Bain chair in business administration or business consulting, but these are the kinds of things that happen. And I think we need to have more conversations around and between departments as well as between universities and within universities more generally. Thanks, Laurie. Timely reminder. I'm very aware we are now over time, and I don't want to push people's patience, and so maybe there doesn't seem to be any more. And just to say thank you so much to all the speakers for your amazing contributions. Thank you for everybody for staying the course for over an hour and a half, and let's continue this. And thanks, Leslie, for that. Yes, South African Brewery is having a seminar room in Commerce faculty. So thanks, everybody. Thanks, Leslie, for all your posting. Thanks for the questions, and let's continue this really important conversation. Thanks, everyone. Bye.